supination, this is what the bones look like. And this is the ulna, and that part of the ulna articulates with the trochlea, and you can see how that would give you a hinge joint. And this part of the radius pivots on the capitulum. And we've said in lecture, and we'll also talk about it here, that really the head of the radius pivots on two different things. It not only pivots on the capitulum, but it also, when you pronate and supinate your hand, the two bones of the forearm articulate with each other. Okay? They have a very close association on both the proximal and the distal end, you'll notice. And they articulate, these are actually articulations that are lined with hyaline cartilage and have little bursa and everything. They're a diarthrotic joint. Okay? And so, anyway, when you pronate your hand, when you go like this, the radius rotates, it pivots on the capitulum, but it also rotates around your ulna. And the ulna and radius actually sort of rotate around each other, and the final result is that your ulna is still in the supine position, but your the two bones are crossed. And your radius is, and notice that the proximal and distal end are still touching. We have the radial notch of the ulna, which accepts the radius, and the ulnar notch of the radius, which accepts the ulna. And they're both diarthrotic joints at both ends. And so the radius kind of articulates around the ulna while pivoting on the capitulum at the same time. And I'll show you on my little model over there how that works. It's just amazing. And the whole thing is engineered just amazingly well. So we used to walk on all fours, and so you see, with the moment we stood up, things started changing, and a lot has changed. There's a lot of differences between the foot and the hand, aren't there? You can't do that kind of thing with your foot that you can do with the hand, can you? Nor do we really need to, unless you're a contortionist or something. But, okay? So that's some really interesting engineering there. And so we see that not only does the head of the radius pivot on the capitulum, it also pivots on the radial notch of the ulna. And that'll be one of our anatomy words, the radial notch of the ulna. We also will talk about the ulnar notch of the radius, which is down at the other end, at the distal end. Okay, and of course, we have this trochlear notch of the ulna. And this is the one I was going to ask you until I realized it was not covered on your lab last week. But so I instead, this is the coronoid process, and so I changed it to coronoid fossa over here. But anyway, that's the coronoid process. When you lock, when you hyperflex your arm, the coronoid process locks into the coronoid fossa. And your trochlear notch hinges on the trochlea. The ulna is also always associated with the little finger side of your hand, and that's always medial in the anatomical position, isn't it? So the ulna is always medial, and the radius is always lateral. And that's good stuff to know for this week's lab. Okay. And so here we see the coronoid process and the coronoid fossa and the head of the radius and the radial fossa. So when you hyperflex your arm, those two proximal ends lock into those two fossas. On the posterior side, we have the olecranon process of the ulna locks into the olecranon fossa of the humerus. See? And so, and you can see there the head of the radius pivoting in that radial notch of the ulna right there. And you can tell whether or not your ulna is a right or a left ulna by which side the radial notch is on, knowing that the radius is always lateral. We'll talk about that. I've asked that as an extra credit question. It's really fun. Do I have a right or a left ulna? And so at the distal end of the radius, we have basically your wrist, the part that articulates with the wrist, the so-called radiocarpal articulation. The carpals are the bones of the wrist, okay? And so as out at the distal end of the radius, it becomes larger. And there are a couple of depressions to accept the two bones, the two immediate bones, carpal bones of the carpals fit right in there. Okay? And this so-called head of the ulna, the head of the ulna is this little protuberance on your wrist, right there. That's the head of the ulna. So, and the head of the radius is an integral part of your wrist. That's the part that you use when you go like that. Okay? Is that that's the radiocarpal. That's an ellipsoid joint we learned the other night. Okay? Okay. The distal radius is often broken because it's mostly cancellous bone. So the reason why we have a bunch of muscles in our forearm is to control the hand. That's what they do. And that's all they do. And so in naming the muscles of the forearm, which we will be doing soon, you got to look and see where the tendons go. And the carpal bones of the wrist form a little channel through which all these tendons all go. They're all in little tendon sheaths, and they pass inside this little tunnel called the carpal tunnel. When you bend your wrist like that, those tendons would want to pop out of that little channel, except for the fact that you have a connective tissue bracelet holding them in. And that on all of these muscles on the ventral side of your forearm, all of those muscles are flexors, because when they contract, they cause flexion of all the hand parts. Okay? So these are all flexors, and the ones on the back dorsal side are all extensors. And that will almost always be in their name. So that'll help you with the naming right away. And so this is the flexor retinaculum, this little bracelet that holds all the tendons into the carpal tunnel so they don't pop out. And so there is an axial view of the wrist showing how the carpals of the wrist sort of form a channel or a tunnel. And these are all those tendons in the carpal tunnel, and we have the flexor retinaculum holding them all in. And the ventral side contains the flexor muscles, and the dorsal side contains the extensor muscles.
What happens in carpal tunnel syndrome?
Well, those tendons are running through these little tendon sheaths that are lubricated with synovial fluid. And like anything, if you use it as 10 zillion times, and you know, these days, if you work in an office a lot, they lecture you about not doing anything for more than 15 minutes, then you're supposed to get up and walk around, which nobody does, but they're supposed to tell you to do it. And you're not supposed to sit at a keyboard for any more than so long before you quit doing it for a little while. And that's because you, as the tendons slide back and forth inside those tendon sheaths, it starts to become irritated and inflamed. And it finally becomes so inflamed that those structures all swell up and the tendons won't go through there anymore. Dental hygienists often run into this problem. I had a lot of dental hygiene people come back to take my class because they had to quit dental hygiene. They had gone through the whole dental hygiene program, were out there in the field, and had to come back and quit and go into medical imaging instead because of that carpal tunnel syndrome. It's common in a lot of professions. A dentist here in town that I really liked had to quit his practice totally. It was really sad to see because he had wrist problems. I don't know if that was exactly it, but something real close. So it's out there, that's for sure, and it's serious. Okay, so, the flexors. And these pictures of muscles you may be discovering are pretty useless, especially when I always ask questions off the models. Every one of us in this room have muscles that appear differently, you know. You just look at us all, we're all different, and all our muscles are different. And so you look in the picture books, and all the pictures are different. And so our standard is going to be just one thing, it's going to be the models, or some, if I don't have it on the model, it'll be some picture I show you. But it'll always be the same picture, the one you're used to looking at. Bearing in mind that everybody's muscles are different, depending on heredity and depending on their activity level. There are actually 3 levels of flexors, one on top of another. We have a deep layer, a middle layer, and a superficial layer. Okay? And so the deepest ones are, and the digits are the fingers. You ever heard fingers called digits? Okay? And so the name of this muscle is flexor digitorum profundus, which is, profundus means deep, as in profound. So that's the deepest layer. Immediately superficial to that is flexor digitorum superficialis, which is right on top of it. Okay? So here is flexor digitorum profundus, and actually flexor digitorum superficialis lays on top. They're not showing that very well. They've cut it away. So this is profundus, and this is superficialis on top of it. That's what it is. So this layer is superficial to that layer. Okay. So those are the 2 deep layers. Finally, the top layer has 3 different muscles. One of them, the middle one, goes to your palm. So you got, on the models, you got to just look where the tendon goes. It's called palmaris longus. And remember, the little finger is the ulnar side. Everything on the little finger side is named ulnar. There's an artery, vein, and a nerve. And there's also flexor carpi ulnaris. So that makes sense, doesn't it? Flexor carpi means wrist. Flexor carpi ulnaris. The radial side is the thumb side, so flexor carpi radialis. So those are perfectly logical, sensible names. Too bad it doesn't happen that way more often, but at least it happens sometimes. So we enjoy it when it does. And palmaris longus goes to the palm. So that's kind of cool. So those are all rather logical. On the back side, we have one muscle sending tendons to 4 of the digits, and that's extensor digitorum. Okay? And then we have extensors that go to the thumb, that bend your thumb back rather than forwards. Okay? And there are 2 of them side by side. One is longer than the other. Brevis is the Latin word for short, as in brief. Okay, so we have extensor carpi radialis brevis and extensor carpi radialis longus. And in the middle we have extensor digitorum. Then on the little finger side we have extensor carpi ulnaris. And you just look and see where the tendon goes. Okay. And then as you continue to go around the front side, you'd have flexor carpi ulnaris. As opposed to extensor carpi. So on the back side we have extensor carpi ulnaris, and on the front side we have flexor carpi ulnaris. So one makes your little finger go forward and the other one makes it go back. Okay? Okay, we've talked about pronation and supination. We have a couple muscles called pronator teres and supinator. So let's have a look at these. Supinator is attached to the radius. How do I know this is the radius other than it's labeled? Because it's on the thumb side, and which makes it lateral. Okay? And so anyway, supinator is attached rather extensively to the radius, and pronator teres, remember that the radius crosses the ulna when you do a pronation? So when you do a pronation, the pronator teres pulls the radius across the ulna. And you see that's just what pronator teres has done. And as the radius crosses the ulna, it spins, okay? And the supinator wraps around it. Can you see how the supinator has wrapped around the radius now? So now in the prone position, the supinator is wrapped around the radius and the pronator is contracted. When we go back to a supination, the supinator contracts and that unwraps it and spins the radius in the other direction, thus pulling you into a supination. See, so can you see how supinator and pronator teres are opposing muscles that work together to accomplish pronation and supination? So those become important words. And there's a nice picture of how the supinator wraps around the radius there. Pretty cool. So, naming the carpals will be a memorable experience for us, but it's kind of fun once you get to learn. And so there are 2 rows. The way I do it, there are 2 rows. The top row is the hard row, okay? And so you just got to learn in order from the thumb. The thumb is the number 1 digit, and they're numbered 1, 2, 3, 4, 5. And so we go, you just got to learn trapezium, trapezoid, capitate, hamate, triquetrum, and then this little one that comes out at you is the pisiform. The pisiform is broken off most models, but I have 2 models in which it's intact. So once you learn the upper row, the lower row is really easy. The bigger one is the navicular. Scaphoid is an East Coast word. Remember I told you that? I'll accept either navicular or scaphoid, but if you plan to work on the West Coast, I would learn navicular. If it's not written anywhere on here, I'll write it for you on the board, just like it sounds. Okay? And the other big one is the navicular, and the little one is the lunate. And so these are the 2 bones that articulate with the distal radius. Notice there were 2 little cups in the distal radius. Remember that in that one picture? One fits the navicular and the other fits the lunate. And the head of the ulna doesn't do much in the way of articulation at all. And there you see a nice radiograph.
Is that someone's wedding ring?
Looks like it, yeah, absolutely. That's gotta be it, yeah. So we automatically identify this as a left hand maybe, huh?
It's crazy. So high up on the.
Yeah.
Well, that's your
Maybe our
palm.
fingers
So this is your
go up.
palm, these are the metacarpals, I should talk about that. And so we name these metacarpal 1, metacarpal 2, metacarpal 3, metacarpal 4 with Roman numerals. Okay? Then we have the phalanges, which is plural for phalanx. Since I will only be asking you one at a time, it's better just to learn the singular. I probably won't ever ask you, give me the name for a group of, or for more than one phalanx. You know, it's kind of like the other one, what am I thinking of? Anyway. So, how do we name them? Each phalanx has 3 bones, a proximal, a middle, and a distal. The only exception to that is the thumb, which only has 2 bones, a proximal and a distal. So we would name this one, that little bone right there, and very often it's not uncommon just to break one of these. Okay? I dropped a weight on my foot once and broke one of those in the foot, and they're named just the same in the foot. This is the first distal phalanx. That is the 3rd middle phalanx. That is the 4th proximal phalanx. What's this one?
5th medial.
5th middle phalanx. So I'll probably ask you one of those. Those are pretty easy, aren't they? Metacarpal 1, 2, 3, 4, 5, Roman numerals. And then I'll ask you 2 or 3 of these carpal bones. Okay? So those are a little bit challenging. We just write them on a card and memorize them and learn to spell them at home.
How do you spell phalanx? It's not in
Phalanx, Phalanx. Phalanx. Good question.
Can you say it one more time?
Phalanx, Phalanx. So there's our picture again, only this time I'm not asking olecranon fossa. This is the olecranon process, since now we're talking about ulna. Before we were talking about humerus. So this is a great picture showing the head of the radius pivoting in the radial notch of the ulna. That's a diarthrotic joint. This one doesn't even label that articulation. Quite an omission. And there's that one again, and we can talk about the coronoid process, or we can talk about, you can't really see the trochlear notch here, but you can see the head of the radius. This is the radial tuberosity. It's a very important feature of the radius because this is the attachment of the biceps muscle. So the biceps muscle attaches rather proximally. Imagine the mechanical advantage that you lose
Yeah.
as opposed to having it attached out here. Okay? Why isn't it attached out here? Because you'd have a muscle outside your body when you flex, you know? Not too good a way to take care of your muscles, you know? So you want your muscles to be inside your body, and that's a rather tedious restraint sometimes, that we have to keep them inside the body. It gives us very poor mechanical advantage. So suppose you do curls with 100 pounds, okay? Imagine the stress you're putting on that radial tuberosity. Just imagine it. That's a pretty strong attachment for it. Even if you do curls with 10 pounds, you know. And so there's a nice picture of the carpals. This is a little feature on the hamate called the hook of the hamate that sticks out. It's an important tendon attachment. You know, can you guess what that is there?
The carpal tunnel.
Carpal tunnel, that's right. Okay, so that's the hook of the hamate.
How do you spell that?
The hook of the hamate.
Oh.
Trapezium, trapezoid, capitate, hamate. And that's the hook of the hamate, which we'll learn, and it shows up nicely on our model. You can just see a little bit of the triquetrum over there. That's not a very good picture, but I probably won't use that for anything. Okay, so let's do show and tell. Who wants to be my reader?
It's right here.
Okay, good. Sounds great.
So my regular stand.
Okay, let's get over here.